Based on this preliminary investigation, the causative organism is likely to be Haemophilus influenzae. A presumptive diagnosis of bacteremia or meningitis can be made at this stage. Meningitis is an infection of the meninges of the brain and spinal cord. Common symptoms associated with meningitis are fever, headache, and a stiff neck. Most cases of meningitis are of bacterial or viral origin. Haemophilus influenzae type B is the most common cause of bacterial meningitis in children under 5 years old in countries with no immunization programs, and is the sixth largest killer among infectious diseases. A mortality rate of 2 to 5% can be achieved by a swift diagnosis and treatment with intravenous antibiotics such as cefotaxime and ceftriaxone. However, neurological deficits and complications occur as frequently as in 15 to 30% of patients. Haemophilus influenzae is a gram-negative coccobacillus with two major types of strains. These are the encapsulated strains and unencapsulated strains. There are 6 serotypes of encapsulated bacteria, with type B responsible for 95% of all invasive diseases caused by Haemophilus. Encapsulated bacteria are clinically relevant as the capsule provides resistance to phagocytosis and complement-mediated lysis. Haemophilus influenzae are a part of the normal flora of the nasopharynx, and therefore are classified as an opportunistic pathogen. This plays an important role in the transmission of bacteria by sneezing or coughing and inhaling droplets of nasal secretions. Although carriers don't contract disease, they play an important role in its transmission. Once within the nasopharynx, Haemophilus can induce infection by two different paths. Encapsulated Haemophilus can invade the bloodstream and spread to sites such as the lungs to cause pneumonia, the meninges to cause meningitis, and other conditions such as pericarditis and osteomyelitis. Non-typable Haemophilus spreads infection through the paranasal sinuses and infection of the middle ear, causing otitis media. Otitis media is the most common bacterial infection affecting children, with an increasing number of infections being attributed to non-typable Haemophilus influenzae. Vaccines for Haemophilus influenzae type B have been used since the 1990s, and a subsequent 90% decline in HIV-related disease has been observed. The direct benefits of the HIV immunization are complemented by a reduction in HIV colonization of the nasopharynx in the general population, breaking the crucial link in transmission of disease and consequent herd immunity.
The patient had 2 swabs taken, one from the ear and one from the throat. Both of these grew normal flora. In the ear, normal flora usually consists of 90% of gram-positive organisms, including Staphylococcus, Corynebacterium, Streptococcus, and Enterococcus species, with only about 10% of normal flora being gram-negative organisms such as Pseudomonas, Haemophilus, and Moraxella species. Normal flora in the throat will also consist of gram-positive and gram-negative organisms such as Neisseria, Acinetobacter, Vanilla, and Streptococcus and Moraxella species. The workflow begins with ensuring that these samples and the patient ID are correctly identified, as well as doing microscopy, including cell counts. To identify these organisms, the process begins with the plating of the swabs onto agar so that pure colonies can be isolated. From there, pure colonies are plated onto horse blood agar to show hemolysis, and if organisms will grow in anaerobic or aerobic conditions. Additionally, the colonies will be plated onto selective or differential media such as McConkey agar to show lactose fermentation and other biochemical traits. Microscopy will also be used to identify the organism by their gram stain and morphology, as well catalase and oxidase tests are done. According to the results, specific tests such as API strips, antibiotic discs, Lancefield groupings, DNase plates, or other selective agars will be set up so the organism can be correctly identified. From the throat normal flora, Moraxella catarrhalis was isolated and is a significant organism. To isolate and identify M. catarrhalis, the process, as previously stated, would be followed. This bacteria would have only grown on aerobic HbA plate, as it is a strict aerobe and would appear as a white, non-hemolytic colony, which was round, glistening, and convex. The gram stain would show that the organism is a gram-negative diplococci and is positive for both catalase and oxidase. However, these traits are shared with Neisseria species. To differentiate between Neisseria and Moraxella, the DNase plate and attributin test can be set up, which will both show a positive result. As much as Moraxella catarrhalis is a significant organism to be isolated from the throat, it is likely not the cause of the patient's illness. It is a commensal bacterium in the upper human respiratory tract and only becomes a respiratory pathogen when the patient is immunocompromised or already has a viral infection or underlying condition such as COPD. When M. catahalis becomes a pathogen, it generally causes an ear infection. However, it only causes 3 to 20% of otitis media infections, with 80% usually caused by Haemophilus influenzae or Streptococcus pneumoniae. In this case, the patient's symptoms align more with bacteremia or meningitis, not an ear infection. Bacteremia or meningitis caused by M. catahalis is extremely unlikely, as infections of this severity almost exclusively occur in patients who are immunocompromised.
Specifically focusing on the blood culture, growth of Haemophilus influenzae was only identified in 1 out of 2 of the samples after 24 hours. In terms of normal flora, blood is sterile and therefore any bacteria found is not normal and considered bacteremia, which can progress to become extremely serious. Therefore, in this case, time is of the essence, as H. influenzae is a significant pathogen in the blood and can become a potential cause of meningitis. Immediate empirical antibiotic treatment must commence when meningitis is suspected, based primarily on an assessment of clinical symptoms and patient history. However, it must be reiterated that diagnosis cannot be made solely on a clinical assessment. Firstly, it must be determined that this bacterial isolate is legitimate and not a contaminant. Therefore, blood samples must be recollected from the patient, replated and incubated. It is imperative that these samples are incubated for at least 48 hours, as it is common to produce no visible evidence of growth after 24 hours of incubation, even with a large inocular of cells. If after 48 hours there is no growth, the H. influenzae is likely a contaminant, and the source must be determined in order to address aseptic techniques and sterilization methods. Common sources of contamination include incorrect sampling and preparation of specimens from health professionals or sterilization techniques within a lab environment. However, if there is growth of H. influenzae confirmed for a second time, it is likely not a contaminant and further investigation will take place. The most probable possibility associated with H. influenzae include bacteremia, pneumonia, and meningitis. This case presents pneumonia-like symptoms, and blood cultures may be positive for H. influenzae in 10 to 15% of patients with pneumonia. However, to eliminate the possibility of pneumonia, we must look back to the other samples, which show no growth of H. influenzae from the throat samples. Therefore, it is unlikely to be pneumonia. Assessment of clinical symptoms reveals febrile illness and lethargy, which in combination with the H. influenzae blood cultures and the age of the patient is an indication of meningitis. From this, a lumbar puncture must be performed in order to collect a sample of CSF fluid and perform further analysis. Workflow begins with macroscopic analysis of the CSF sample, followed by microscopic inflammatory cell counts. Samples are also tested chemically for presence of protein and glucose. CSF cultures will be prepared and plated on HbA, MAC, and chocolate agar, and a gram stain will be performed. Following this, blood samples are plated onto agar in order to isolate pure colonies. Pure colonies will be plated on HbA, both aerobic and anaerobic, McConkey, and chocolate agar. Haemophilus influenzae, when correctly identified, is a facultative fastidious anaerobe that grows on chocolate agar, appearing as large, round, grey, opaque, smooth colonies. There will be no growth present on either HbA plates or McConkey's agar. A gram stain will be performed and morphology determined with microscopy. Results will show gram-negative coccobacilli. Following this, various biochemical tests will be performed to reveal both catalase and oxidase to be positive. From these results, specific tests will be set up in order to confirm the bacterial identity. Cytalism plate, positive on HbA, negative on nutrient agar, antibiotic sensitivities, nitrosephin test, API-NH strip, and X and V, NAD, and hemin positive. Lastly, these tests are finally confirmed by serotyping using PCR and latex agglutination to HIB, which is of utmost importance for epidemiological purposes, and New South Wales Health must be notified if this is H. influenzae type B.
There are 2 vaccines that target HIB disease, one that protects children and adults from HIB disease specifically, and one that protects 2 to 18-month-old babies from polio, tetanus, diphtheria, and whooping cough in addition to HIB disease. That the patient is infected at 2 years old raises concerns about immunization. Based on the test results and patient symptoms of fever and lethargy, there is a significant chance that the patient is suffering from meningitis, in which case other symptoms could include headache, nausea, drowsiness, a stiff neck, and vomiting. In order to confirm this, we would obtain cerebrospinal fluid via lumbar puncture and gram stain culture, perform a complete cell count, and analyze glucose and protein levels. Bacterial meningitis would be signified by a raised white blood cell count with neutrophil predominance, along with lowered glucose and raised protein levels. If at any point during treatment the patient is believed to be at risk of herniation, a non-contrast CT head scan should be performed instead. Additionally, if the patient has experienced a seizure or displays unstable vital signs or coagulation anomalies, delaying the lumbar puncture should be strongly considered. Monitoring the patient's vital signs will be extremely important both for tracking disease progression, but also because it impacts on diagnosis techniques as mentioned. Delays of 3 to 6 hours are correlated with increased mortality. If there will be a delay in diagnosis, empiric preemptive administration of ceftriaxone and vancomycin should be considered. HIV disease is specifically treated with cefotaxime and ceftriaxone. Furthermore, prophylactic treatment with ciprofloxacin, rifamycin, or ceftriaxone should be administered to those who have been in close contact with the patient. After treatment, the most important thing to look for is potential complications that arise as the result of meningitis, such as hearing loss, ataxia, hydrocephalus, cranial nerve palsies, seizures, and cognitive dysfunction, which have to be diagnosed and treated accordingly. Another thing to consider is the potential of comorbidities to meningitis that are caused by HIV disease, such as osteomyelitis, cellulitis, pneumonia, and epigitis that could manifest over the course of diagnosis and treatment. However, treatment of the initial HIV infection should be enough to account for this. Furthermore, as mentioned earlier, the age of the patient and the ages at which the HIV vaccines are administered raises concerns about immunization for other potential diseases. Lastly, due to the nature and potential severity of the case, occupational therapy for those involved in the case should be considered.